We are now going to talk about the role of policies, government healthcare schemes, and the importance of quality in the time of crisis in the diagnostic industry. So I am joined by subject matter expert Dr. Atul Mohan Kochar, CEO NABH, Dr. Girdhar Gyani, Director General AHPI and Ex-Secretary General Quality Council of India, N. Venkateshwar, CEO of NABL, and Dr. Arjun Dang, CEO Dr. Dang Lab, and Mr. Chatterjee, CEO Apollo Preventive Healthcare, and may I invite Dr. Rana Mehta, India Health Leader PwC, to moderate this session.
You know, it's been a strange world in the last 3 months. I think one of the words we've heard more than anything was testing, testing, testing. So I have this distinguished panel to talk about, you know, how testing is important, how diagnostics is important, how does it link with our country's Atma Nirbhar. So one of the things as we start, you know, diagnostics only constitutes 5% of the expenditure in healthcare, but it's responsible for over 70% of the clinical decisions which are made. In India, we still have some of the lowest testing in the world from a lab perspective. Very few, on a single sample, it's estimated we just do 2 tests. That's compared to 8 in the European Union and a panel of 15 in the United States. The pandemic, I think, has brought down the need for testing, but it was always there. It's also a very unique industry. It was always at the back end. Today, I think it's got a lot of publicity, which it actually deserved. Because if you look at it, it's been one of the most efficient industries, both in terms of pricing and its ability to control costs as such. The costs of testing in India are amongst the lowest in the world. It's also an industry which has 3 components. So it's just not the testing, but if you break it down, there's a logistic component to it, and there's a retail component and a clinical component, which brings all these 3 together. And as a country, if you look, you know, close to about 8 lakh people are employed in the lab diagnostic industry. And the way we are growing, that's going to double in the next 5 years. And one of the other areas is that the gender diversity is very high. You have a lot of women who actually work in this industry. It's also all over India. It's right in an urban setting, it's in a rural setting, and it has entrepreneurs who come in and make this one of the most dynamic industries. And also one of the most important, because if you don't get your test right, you're going to get a wrong diagnosis and the whole treatment will be impaired. So no better time to do this. And I'll start off with Dr. Girdhar Gyani. Dr. Girdhar Gyani, as I said, 4 months is a very long period and things have changed. You know, healthcare we thought was always recession-proof. But what we've seen in the pandemic, it's not recession-proof. A lot of the hospitals have got impacted, and especially the smaller ones. Do you think this is a temporary phenomena, or is the viability of some of the smaller hospitals actually coming into question? Dr. Gyani.
Thank you, Dr. Rana. Let me begin by saying that healthcare has been in a bit of problem in last 2 to 3 years. The financial viability also has been in question for the many reasons. You know, this pandemic has worsened it for the simple reason that once we brought the lockdown, and by knowing that this is a highly contagious virus, there was an advisory from the government that we must stop the non-elective surgeries, and even the OPDs were advised to be shut down. Now this brought down the patient footfall in the IPD to 20% to 30% at best. Even in OPD, we got only 10% visit by the patients. So that obviously brought down from 22nd March, full April, full month of May, the patient footfall was, as I told you, 20 to 30% in the IPD. Now, obviously, that brought down the EBITDA margins, and hospitals were found to having negative EBITDA in these 3 months. So that is the simple reason. Now, even now, when we have opened up, and in fact, the many state governments are advising all hospitals to open it up and encourage patients also to go for the all possible surgery, whatever they want to do. But still, there is an element of fear among the public, and they are not really focusing on, or they are not encouraged to go to the hospitals. So this is one reason that there is a shortfall in the revenue and EBITDA down. Now coming to this, that is it going to be the long term, or is it a short term phenomena? I'll put it like this. Healthcare, since it became the political issue, I think starting from 2018 onwards, when the Ayushman Bharat was launched, that more and more patients will be coming to the hospital through the schemes. The schemes like Ayushman Bharat, CGHS, ECHS, ESIC. In a way, it is a good sign because the people will not be paying out of the pocket. Somebody is paying for them. Government is paying, insurance is paying, employer is paying. But the main issue remains here is that while fixing the pricing for these procedures, none of us mean government included, have done any scientific study. And whatever prices have been fixed up are on the ad hoc basis. And that is the reason that we got more patient, but the compensation or the reimbursement which is coming to the hospital is very low. Now this cannot be allowed to sustain for longer time. And I think the industry has made its position very clear to the government that they will not be able to sustain if there is no pricing done or the costing done on the scientific basis. So I think with this issue, that on one hand, we are trying to bring universal health coverage, but on the other hand, we are making, because the government does, you see, the point is like this. If the government wants to bring universal health coverage, one is like Malaysia, like Australia, you have your own beds. But in India, that private sector has got 60% of the IPD beds and 85% of the tertiary care beds. So that means government will have to depend on the private sector for delivering the healthcare schemes, insurance scheme, welfare scheme. And if that is the case, the government has to provide enough budget and to fix the prices on scientific basis and compensate the industry. That is the only way it can sustain.
Thank you, Dr. Gyani. I think what you're saying is, if we need to provide quality care, it comes at a cost, and that cost needs to be met. And for a long period of time, I think there's a discord between what the schemes pay and what is it viable for a hospital. And in the current circumstances where volumes have even come down, this becomes even more relevant to put this in place if we want the industry to have a V-shaped recovery. Mr. Venkateshwaran, I think one of the things, like I alluded to, was testing. But I think when it's testing, it's also the quality of testing. If I get a false positive, if I get a false negative, under normal circumstances, it could still work. But in a pandemic, I think it could have a huge impact, not only for the individual, but for society as such. So how do you think while NABL has played a role, but it's still limited to a minuscule numbers of labs. So how do you think the quality issue needs to be addressed if we have to have a robust healthcare system going ahead?
Thank you. NABL per se, National Accreditation Board for Testing and Calibration Laboratories, we are granting accreditation to medical laboratories based on an international standard, ISO 15189. The standard itself has components on management system requirements and technical requirements. During this pandemic, we were focusing more on the technical aspects, where our assessors gives the lab a sample to do the testing. So the quality is being ensured by giving a sample to them to do the testing and what the results they are able to obtain. So based on that particular results, then only the competency is being determined by the assessment team, and then we recommend them, yes, they are capable enough to do that particular testing. So the labs are following a standard, and there is a quality check in place. Before they apply to NABL, they generally do a retest work. They do the testing first. They get trained, and then they get practice. They have an experience onto that, and then they apply for NABL accreditation. So once when my assessment team goes there, they give the blind sample to them so that they can demonstrate that particular testing. So based on the demonstration in testing, and the test witness takes place, and then the laboratories are being accredited. So that means the lab will already have the reference material, the quality checks, the calibrations done, and interlab comparison, everything will be in place. Once things are in place, accreditation is being granted by NABL. That's how the quality infrastructure is being made into the labs.
So as you pulled this during the pandemic, did you see any particular challenges which came out? And as the pandemic abates, hopefully, what would be the whole area to make this grow further? Because I think the quality becomes very, very important. Everybody from a doctor to the end patient is actually worried. Is this report correct? Because so much hinges on that now.
Yes, because our accreditation process, timelines also are very wide. During this pandemic, what we try to do, because the assessment team cannot move to the place or we can't go to the site. So we made the assessment remotely. So the assessor will be there in their place through video conferencing or through the mechanism of showing it virtually. The assessor could interact with the particular lab, and the lab person will be there in the lab, and from the sample collection facility onwards, how the sample is being taken from the patient, that also is being witnessed by the assessment team. So from that initial stage, then how that sample moves from one place to other place, that is also being witnessed through the virtual mode. And the full particular process, it takes maybe somewhere around 6 hours to 8 hours. The full particular time we are there, the labs are under the surveillance, and it is being checked fully. So the main bottleneck, what it was our assessments are based on on-site assessment. So during this pandemic, we just modified by conducting it remotely. And since it was one particular parameter of RT-PCR RNA virus testing, we could have one technical assessor and the lead assessor where both could consult and both could see the particular process, the practical demonstration, and then we could come out with a solution of yes, we can grant them accreditation or not. And second thing, from lab point of view is concerned, when they wanted to apply, we created a small short thing into our website, the links, so that the moment they click the link, they can go to the website and start filling the details what they wanted to know. And second thing is, we have given them an option of self-declaring. So for each and every requirement, the lab goes through those requirements. For example, equipment, the calibration of an equipment. So the lab goes through everything and then self-declares all these particular things that yes, they are complying to those requirements and standard. So based on that self-declaration, what the lab has submitted to us, our assessment team checks in the site whether whatever the lab has declared is right or not. And all the documents and records are being seen. And based on those things, the laboratory's credibility is being ensured. And we also ensure that whether the lab could compare their results with another lab, whether they have got the reagents with them, whether they got the kits with them, and all the protocols and procedures are being followed by them. There is an interviewing process with the particular doctors as well. And after ensuring all these particular things, the accreditation is being granted. So the quality is prime focus, and what we made was quick decision making. We took it. Either we grant them accreditation at that point of time, or then we tell the lab, no, you're not competent enough and we don't give you accreditation. So denial decision also has been taken by the assessment team at that spot. And in some situation where the lab could do something, but could not do some minimal activities, for which we did the verification audit. That means a follow-up audit was being done, and then we could grant them accreditation. There are situations also, after we deny accreditation, the lab gets themselves trained. They practice number of the samples doing the testing, and then they have come back to us, and then we have did an assessment again quickly, and then we could gain them accreditation also. So all these particular things we could help the laboratory to bring up to a standard. Because many a times the main challenges what they ask is, once you have denied accreditation, how could you give them in another 7 more days? So I used to tell them that the process, whatever we are doing it, once they get trained, because there are nodal institutes which trains them. There are assessors who are giving the training to them. So after giving the training, they practice it with other viruses, and we are focusing on those things, and we have granted them accreditation. A lot of challenges was there because assessors giving their time even in the evening time, and we got an accreditation committee where they also round the clock they were working. Even our officers, I need to compliment NABL team for the entire work what they did by 24/7 for completing this task. A lot of pressures also was there without diluting any kind of requirements or not even a smallest slip on the quality requirements. We could achieve these things.
No, I think, congratulations. I think what I hear is, so much flexibility in unprecedented times. And, just by denying someone, you just don't improve the system, because we still have a shortage, and no matter how many labs we have on board and what quantum of testing we need to do, that discord will be there. So I think that flexibility which you allowed, I think is sure. And even after the pandemic, I think that mechanism to get accredited becomes much better. I'll next go to you, Dr. Kocher. So, the NABH accreditation has been there, and, it's now the gold standard. Prior to this, people would aspire to JCI, but JCI is expensive. While it's a US globe, it may not be relevant. So I think NABH has done a lot of work bringing it to India, making it relevant to India. And healthcare is about three things. It's about, infrastructure, it's about process, and then it's finally about the outcomes. So two things I want to ask you. I think in India, the NABH accreditation still has been very slow. If we look at the large number of hospitals we have, and especially some of the smaller hospitals, which Dr. Gyani spoke about, they're still reluctant to get accreditation done. So that's slowing it down. But as a patient, as a doctor, I'm not very sure of the quality or the outcome. I could look at the infrastructure, I could look at the process, hope it's right, but it's the outcomes I'm paying for. So how do you think this should take off? And one of the questions I think a lot of people are asking is that, is this quality same in the public sector and the private sector? And why has the public sector been so slow or reluctant to actually take forward? And is there merit in now making this mandatory?
Yeah, Dr. Rana, I think I'll take them as three different questions actually. So firstly, thank you so much for saying that NABH has laid down the foundation of quality in healthcare in India, which is a reality from Dr. Girdhar Gyani's time. He has been instrumental in laying down NABH. And NABH today is a very strong family. Our partners and colleagues of 8,500 different categories of healthcare organizations. We are running currently 19 programs under accreditation, certification, and empanelment category. So, which is a large number. We have the mandate to create standards, and these are homegrown standards. I mean, they are very, very India-centric. Yet they are adapted, and we are accredited proudly to say by our international organization of ISQA. And even 13 countries currently have shown interest in endorsing our standard, adopting our standards, and Muscat, all of Oman, Philippines, all of SAARC countries, they are very keen to get NABH, and already about 4 countries, they are already there as part of the NABH international program. But talking about India, actually, you very rightly pointed out that India is a huge country, and we are still a developing nation, and the diversity and the socioeconomic strata is so different from tier 1, I mean, the metros, to tier 2 cities, to tier 3 cities, that things are very, very different. And the socio-cultural changes in parts of the country are very different. I mean, the reality, you are very well aware of what is it. So talking about the smaller hospitals adopting it, well, NABH made a beginning in 2014 with an entry-level certification program. So full accreditation program has been very successful. Currently, we are partnering with about 700 big hospitals, and they are big hospitals, and they follow a full accreditation program where every quarter they submit their key performance indicators and outcomes, and that I'll just come to in a moment. But the smaller hospitals countrywide, if we were just to look at the IRDAI site, the Rohini portal as we call it, there are 19,000 smaller hospitals which are registered with IRDAI, right? But there are many, I mean, it could be a threefold number which are not yet empaneled even with IRDAI on the path to quality. So this is, you very rightly pointed out, we need to create a culture of quality in these standards, these smaller setups. And for that, NABH launched its entry-level certification program. We have named it HOPE, Hospital Online Platform for Entry-Level Certification, which is a wonderful, very objective, very transparent app-based mechanism. So there is no discretionary thing. It is very easy to implement. And going forward, this is going to be a game changer. And currently, I would say about 4,500 hospitals are already enrolled for this program. But still, there's a long way to go. I mean, it's that Rudyard Kipling, a long road and long way to go before we sleep. But that's a reality because of the India-centric changes. But NABH will not hesitate till we take quality to the last man in the line. And you very rightly said that till every person, I mean, they should be exposed. And our aim, God willing, is to aspire to make every let's say a single hospital, single chair hospital clinic, I mean, not a hospital, a clinic, a doctor's clinic should also follow certain standards protocol. And that change can come only when we start ingraining our medical graduates, our paramedicals at the learning stage itself, at the MCI itself, the Board of Governors itself, and they've taken a very proactive view. And I think very soon we'll be getting a mandatory chapter on quality, patient safety, and accreditation or certification as part of the normal medical curriculum. So that we are trying very hard for that, and we are succeeding to a large extent. So going forward, the future is very bright. And coming now to the role of quality, I mean, in pandemic, you were asking Dr. Venkat, like the changes during pandemic. So I would also say that this pandemic has shown us, I mean, different challenges, is thrown at us different challenges, but has also given us opportunities to have an introspection. And this is the time when we see that quality has made meaningful change. All hospitals, all our 8,500 odd hospitals which are enrolled with us in different categories, whoever were they have fared better, much better than those who are not empaneled. And that's a truth. Actually, they have adapted to the scenario very well. They already had disaster management as part of their standards. They were used to drills, so they adapted very quickly. I mean, results are different actually because the virus is very new and there is no right or rational treatment currently, and every day it's an evolving thing, and so many gray zones are there as far as treatment testing is concerned. But going forward, looking back as an analysis, the lesson learned is that quality is very important for any setup, and it makes us prepared to handle such uncertain and large challenges. Right? So that is a given. So quality is the need of the hour. And point two is we need to take it to far-flung areas of the country. We are succeeding, but there's a long way to go. And we will not hesitate to take it further. Third point was the public-centric. I mean, that's a googly actually. The public-funded institutes, they face different challenges, but you very rightly said they don't treat the patient going there are not children of the lesser God. I mean, if to say. So you are very correct that they have to follow norms. They must follow, and we will be helped actually if government give us some legal teeth also. I mean, more teeth. NABH today is fortunate to partner with National Health Authority as a benchmarking mapping, so that our accreditation or certification is benchmarked to a 15% gain for the NHA hospitals, and certification gives them 10% benefit. But that is a start. But still, unless the accreditation, as there are many countries in the world who have made some sort of certification or accreditation mandatory. We are a voluntary organization, and we cater to, as Dr. Venkat also said, only to people who come to us, who approach us. So if there was a mechanism, and we can scale it up, very, very transparently, because we have very strong foundations. We are a very integrity-based organization. We enjoy good reputation mostly, barring one or two incidents. But our core strength is our integrity, probity, propriety. So, these things, you can say, we can scale up our operations to anything if government gives an opportunity to take quality and certification to far-flung areas of the country. But public funded institutes also have made a change. There are certain states which have taken a lead. Gujarat is one model state where not to talk about medical colleges, every PHC also is NABH certified. That is one area. In Delhi, there are 9 institutes which are big to small. And just to place on record, all our aims, actually they are compliant. They are compliant to our standards, though they do not carry a formal certification because of whatever reasons, but they are compliant. They have good and robust quality teams. So government infrastructure is no less, actually, barring the patient load, which they cannot refuse, barring the free charge. But still, I feel that all of them should be going in for a mandatory accreditation or certification. So that's a very valid point. And NABH is ready to partner.
No, thank you. And I think you're very right. See, ultimately, I think it's, if you look at the JCI accreditation, it's not mandatory, but if you tie up with a payer, any insurance company, it will not pay unless you are accredited. So I think there are ways of doing that. And like Dr. Gyani said, a lot of that is because the payment, especially from a lot of the public sources, is inadequate. So I think that as that ramps up, I think it will give an impetus. And I think we should put in that accreditation is going to be mandatory, because going ahead and, making our healthcare system larger and robust without having quality is actually a double risk. So I think, like you rightly said, we need to.
Just to add one quick line, actually, because JCI, Joint Commission, has been around for 70 years. We are a teenager, actually. NABH is a teenager, and a very restless teenager to say. We are just 15 years old. And NABH, JCI came in 50, so they are already about 54. So they are 70 plus. And there is a purely insurance-based mechanism, actually, if we were to follow the US. And it costs about maybe 7 or 8 times. They cost upward of 1 CR to get a basic JCI certification done in India. So ours is a very low-cost model. Ours are India-centric standard. They are mapped to international organization. And any day, we are, I would say, representing NABH and knowing NABH as a principal assessor, as a clinician, and belonging to a public funded institute. I've served in Maulana Azad for nearly 30 years now. So, I can say that our nation is and our standards are most suited for our country. And they have stood the test of time, and we are ready to adapt to without diluting to any challenge, actually.
No, great to hear that. So good to hear that we're in the hands of a nimble teenager who's willing to innovate. Puts us in a good place. Dr. Arjun, I think I'll go next to you. And, one of the things which Dr. Dang's lab is known for, I think, is quality. So, quality has always been forefront. And the second part is, personalized care. So very different, but, you in the private sector, you sort of are known for those. But I think the innovation you've also done within the COVID pandemic has been seen by everyone. But what do you think are some of the challenges as we get into a post-COVID world and, testing becomes integral to what all of us need to do? Arjun.
Thank you. Thank you, Dr. Mehta, for that question. And thank you for having me. I'm extremely humbled and honored and privileged to be within this esteemed panelists on the ET Health Diagnostics Forum. So Dr. Mehta, starting with your first point, regarding quality and personalized care. So here, what we've actually tried to do ever since the inception of the laboratory was to try and make pathology more of a front-ending specialty than a back-ending specialty. So usually what happens is that people come in, they interact with the physician, he writes down some tests, and then they simply go to the lab, give their sample, and then for them, it is actually just some readings or values on a piece of paper. Here, what we've tried to do is that starting from the pre-analytical phase, that is, if there's a small baby who's come with his mother to get a sampling done, we personally do the sampling ourselves, not only to establish that personalized connect, but also in a lot of cases, it's actually scientifically helped us to get history from the mother. Now, if you have a baby who has some symptoms and the doctor has written some tests, just interacting with the mother, even for those 3-5 minutes while sampling the baby, has gone a huge way and helped us give out better reports and obviously add value to the report as well. Coming to also the COVID pandemic that we have dealt with and are currently dealing with. So needless to say, this is an ever-going process of constant learning. Every day there are new breakthroughs and new things that are added to science. But what is actually required in the COVID pandemic, and we feel very strongly along with quality, is also creativity. Now, to actually cater to the masses, a very high quality test that also is given at a very cost-effective rate is definitely the need of the hour. And keeping this in mind was the reason that we started the drive-through services as well. The drive-through services are also being ramped up to accommodate more walk-in patients also who can get sampled in the whisk. And multiple tools and techniques have been put in place so that not only the sampling time is reduced, but also ensuring maximum safety and minimum exposure, not only to the patient, but also to the medical staff who's sampling the patient. Coming to again, the quality of the PCR test and what we are doing currently, obviously the ICMR has given us very fixed kits that we can use and we are following those norms. But also what I feel is being missed largely by a lot of labs is the pre-analytical phase. How well trained is your technician who's going into someone's house to get a nasopharyngeal swab? So actually very, very stringent training is required even in the pre-analytical phase. And then again, obviously the molecular biologists who are running the tests, the MD and the PhDs, the entire team will obviously follow the laid down protocols. But actually this pre-analytical phase where the sampling is actually being done, apart from establishing very stringent norms of infection control, even sample collection plays a huge role in the report that we get, definitely keeping in mind the false negatives also. So training the pre-analytical phase for the technicians is also very important.
No, I think that's important. I think the single most focus on quality, I think, especially in the current scenario, becomes very, very important because the implication and ramifications are very different. And we've had people who've come back and said we tested negative and then tested positive the next day. While we all know the RT-PCR, has its own sensitivity and specificity, but then again, we need to strive to do the best because for a patient, a wrong report could mean a lot. Dr. Sougat, I think one of the areas, which is very important in the diagnostics is obviously how does it lead to preventive healthcare? And this is becoming the cornerstone of most companies. So most diagnostic companies also see themselves more as wellness companies. But the current pandemic, and I've not done my health checkup for, I must confess, 6 months now, though it's mandatory in PwC, predominantly because there is a risk of going and getting it done. But that also has long-term ramifications because a lot of disease in India is detected at a much later stage. And assuming that we don't have preventive checkups done for about a year, it's going to be. So how do you see this model morphing? And what's been the impact on your business as of now? Because Apollo has been a pioneer in this business.
Sure. At the outset, greetings to all of you all. Namaste, and to all my esteemed panelists. And at the same point of time, I would like to thank ET Health World, because there could have been no better time to set up this diagnostics summit, the India Diagnostics Summit, than to what we are today. Having said that, at Apollo, to begin your question first, Dr. Mehta, more than the aspect of, I would say, taking strategies on the revenue loss, the strategies have been how to make the risks negative for losing lives. And Apollo has been working with the state and the central governments across the country to help increase the infrastructure and also the basis of the which the various kind of situations which we are prevailing and facing today can be taken care of. Now, before I come to the point of the preventive health check and how it's getting impacted otherwise, I'd just like to throw a few numbers. And those are the numbers provided by WHO. So out of the 7.7 odd billion population, some 71% deaths are occurring due to NCDs alone, which is the non-communicable diseases. There's a risk of 15 million people who are suffering premature death in NCDs. Another 80% of the deaths actually originate from the lower income and the middle income groups. And going forward, there's a projected USD $35 trillion cost, which are going to happen on healthcare from 2012 to 2030. And keeping in mind, this was all when COVID had not broken in. Now, having said that, and looking at the way the things are on the present day, if we are to mitigate this kind of a risk, because healthcare and preventive healthcare, the way we see it, are not two opposite sides of the coin. It's kind of the same side of the coin because one leads to another. And if we are to actually build up a country which is Atma Nirbhar Bharat in the times to come with a strong economy, we need strong people. We need less of health issues. We need a country which is more aware about not only their developments but also their self. And there is no other way by which these numbers can be averted or these situations can be averted unless and until we bring the intervention of technology into the business. Now, when we talk of technology, if you look at the spread from the entire diagnostics market, from the private to the government, so in fact, Dr. Gyani already had indicated in a big way how the hospitals and how the sectors have got affected with the COVID times. I guess with Apollo, things have been no great difference. But then, yes, despite maintaining the government protocols, I would say from the patient's point of view, two things came out. One, there were a group of people who were reluctant to come into the hospital unit with the fear that they would get contaminated here. Why didn't? There was another group of people who were actually wanting to come into a hospital unit with the understanding that, probably they would be more safe there. So I would say the thoughts were two very different in nature. And we tried our best to make sure through our communications at the local level and also at the various regional levels to make sure that we project the right kind of a picture from the institute is concerned, where we share the way by which we have been tackling the hygiene parameters, the various parameters by which we are maintaining the cleanliness, safety measures to ensure that the people coming in, the patients coming in are never at a risk. Now, before we come to that, there's also a split which we see between the entire healthcare synopsis, which is the private and the government. And then there is a pathology and the radiology, which is the 80-20 or 70-30 split. Then we have the hospitals and the non-hospitals, which comprise about another 50-50 split. And then we come down to a tier 1, tier 2, and tier 3. Now, tier 1, definitely we have made our good grounds. Probably we are doing about a 40 or 50% of the market share with respect to tier 1 business. But to tier 2 and tier 3 are where the challenges lies. Now, reach is one part of the question. Quality, as Dr. Kochar and Dr. Venkateswaran both mentioned, is another great effort which both NABL and NABH is taking up to ensure the quality and the scalability out there. But at the same point of time, there's another point which goes, and that's a point of worry, is the manpower. Because while quality and processes can be maintained, there's a huge amount of attrition which happens at the manpower level at this various diagnostic labs. And to train a manpower, it takes a lot of time. I mean, by the time you actually have somebody who is well trained to come and address a patient's need or do a test particularly in a right way, it's almost 3 to 4 months of time. And in another 6 months of time, the person leaves the organization and goes somewhere else. So that's one entire fallacy in the system which we have today. And that's something which we are addressing, and nothing can better walk up if we can walk through aspect of constant training and advanced mechanisms where we develop a pool of talent on the way through, which can always be curated and always be nurtured to ascertain to a particular need. Now, coming back to technology, and that's something which Dr. Dang also spoke of, that is getting into the preemptive and the historical parts of the patients, of the mother to the child. So we have been working very hard together for a lot of time to work up something on the data intelligence part, and in the increasing prevalence of the chronic diseases which are the necessity of the efficient diagnosis in the currently today. There's a lot of technology which is coming across on the POCT, which is the advanced point of care testings. We are also looking at probably a lot of technology coming into in the radiology department, in the in the fish segment, which is called the fluorescent in situ hybridization. So while we are moving towards a lot of tests on that segment, we are also trying to build up a technology which can become a life of yours and a life partner of yours on a day-to-day parameter. And that's something to the level of what we call predict, prevent, and overcome. So when we say about predict, prevent, and overcome, we are trying to build up a lifestyle disorder-oriented program by converting it into a friend of yours, a buddy of yours, and AI and intelligence, which will be the only other methodology which will help out reach out to these disproportionate amount of, I would say, very disorganized population into the tier 2 and the tier 3 cities, because the availability vis-a-vis the inhabitants of these two sectors are not exactly very cohesive. The market is somewhere else, the healthcare institutes are somewhere else, we are somewhere else, unlike in the urbans where it is probably all measured in a 40 to 50 kilometer radius. That's not the case in the tier 2 and a tier 3. So technology will definitely make the only, I would say, the way through in the times to come when it comes to intervention of the new age of diagnostics business. And I would say collectively with the government and the policies and the interventions of the training at the manpower level, I think technology will only be the best befitting solution to eradicate all those adverse needs which we have at this given point of time.
Right. And I think it's also important technology, you can scale it up, replicate it, because, ultimately, if you look at, what is the percentage of people who use diagnostic services, it's very, very low in the country. Like Absolutely. I said, even every sample we collect, we just do 2 tests compared to 15 in the US. So even the number of tests, and India is very strange in a way that specialized tests are considered based on a monetary value, not on the specialization of the test, which is again unique here. So I'll go back to Dr. Gyani. And Dr. Gyani, I think we go back to the point that going ahead to make this whole system sustainable, whether it's on the hospital or the diagnostic side, it comes down to the payer and the ability of the payer to make it viable. So I think 2 things you mentioned. One was that there's huge variation in price between what hospitals charge cash patients, insurance patients, scheme patients, PMJY patients. And secondly, as we move more towards a reimbursed-based main model, besides the low prices, there is also a huge payment risk that the payment does not come in time. So it's a double whammy for a small provider. I've done it where I have low margins, but because I haven't got that for 6 months, it also impacts my working capital. So what is the mechanism you think we as a country, both the public and the private sector, should be putting in place so that, when the next pandemic hopefully doesn't occur, we are much better prepared for it?
I will talk even for the pre-pandemic area, because this is a common issue. I'll give you one example, because pricing you are talking. Let us say there is a price in the kept in the PMJY, that is Ayushman Bharat. The procedure is general surgery, anterior resection. The price is 28,500. Same procedure, Maharashtra government, there is a state scheme, they pay 40,000. Same scheme in Arogyashri, Telangana pays 50,000. And if you go to the latest scheme of the state scheme of Karnataka, the same procedure is 70,000. I can give you the list of so many procedures where the different governments are fixing up the reimbursement rates differently. This only shows, actually this data we have submitted to the Supreme Court now. The case is hearing is coming on 19th. You know, this only shows that how we fix up the rates for reimbursement for different procedures. If I tell you, if you go back in 2014, the Ministry of Health invited tenders from the hospitals to give the rates for different procedure for the CGHS. Now, can you believe, you know, that you are not buying potatoes or onion and you are inviting tenders, and whichever is the lowest one, you buy onion from them? Are you doing the same thing here? If I am a 50-bed nursing home and there is a Apollo hospital with a 400 beds hospital, obviously there will be huge difference in the rates. But the person who quotes for 50-bedded hospital, that will become the standard for the entire industry. Whether Apollo or Fortis or anyone, they will have to carry out that procedure at that particular rate. World over, there is a categorization of the hospital based on the secondary, tertiary, quaternary care, depending on the multi-specialization hospital or single specialty, depending on the location where you are. You see, you can set up a hospital in, let us say, Bulandshahr at 30 lakhs rupees per bed. But the same bed, if I have to do it in Delhi, I need 80 to 90 lakhs. So what I'm saying, there is a huge variation in the investment of creating the bed. But you can't apply the compensation at the same rate. And I have given you the example already, how even the government schemes are paying differently for the same procedure. We have actually done a study at AHPI. Our colleague at FICCI also did the similar exercise, and we have shown them that the compensation paid under the CGHS, we have done the actual expenditure drawn from the various hospitals, is varying from 30 to 55% for the 25 selected procedure. So I think this is the problem. The government has to do now is do the costing. In fact, they had appointed a committee under the Department of Health Research. I was the party to that. This exercise started, but it was given up halfway through. You see, once you do this study, whatever cost is coming, then under the, let us say, Ayushman Bharat, you can tell the hospital, because this is a mass scheme, the cost is coming 100, but we will pay you 70 rupees because we are going to give you volume. It is acceptable. But what is that 100 rupees? We must know that. So I think this is the beginning of the whole problem. The healthcare industry, you see, I will tell you that we are rated at 129 out of 189 nation on HDI, Human Development Index. Actually, you are very familiar with that model. This Human Development Index is based on education, healthcare, and per capita income. Only 3 factors. Why we are so low? Because we never bothered that we have to improve on the HDI. If your policies of the government are kept on mind that we have to improve our HDI, your education will improve, your healthcare will improve. Automatically, you know, the income per capita also will increase, your productivity will increase. Healthcare is so important. I will say we have woken up only last 4 or 5 years that something is to be done in healthcare, but I think this is going to take some time. And the issue that private healthcare is expensive, it only comes from one aspect, because people go to government, it is free there. And when they come to the private sector, I did a study for the Delhi government hospital. Dr. Kocher is here. And when Dr. Satyendra Jain was the previous government, the minister, I just worked out a simple way. What is the cost of maintaining per bed per day in a hospital like Dr. Ambedkar Hospital? It came out to 8,500, whether there is a patient or no patient. And Satyendra Jain that time told me, no, it is actually now 10,000. He himself, increased the one. He said, we are spending 10,000 rupees per day per bed. So I'm just saying that if a patient comes to a private sector, and if we tell him, okay, for 3 days, you have to pay 30,000, he will say it's too much. Because we do not know that in the government, in the ordinary secondary care hospital, the cost is 10,000 rupees per day per bed. My suggestion will be that in the government hospital from now onward, they should start billing. Invoice 30,000 for 3 days, subsidy 30,000, bill is zero. This will generate, the awareness, consciousness among the people for value for the healthcare. Today, actually, that is not there. At the same time, I think we will have to restructure even the private healthcare. We will have to see how we apply the quality tools, how we make the services more efficient. There are ways and means we can bring it down, but in any case, it has to cost. And you yourself said for delivering the quality healthcare. And I keep saying for Dr. Kochar and my friend Venkatesh, that quality healthcare is going to cost. Absence of quality may cost you the life. So I think this is the way, we have to develop, and government has to understand this. Finally, I will say that if government realizes that yes, this is actual cost, which average person cannot afford, you introduce co-payment scheme. I can afford the cost. Okay, I will pay to the hospital. A poor person will not pay, give him the free. In between, middle class, you compensate by 30%. So that co-payment actually will overcome the issue. But our governments are nowadays, competing. No, I'll provide entire population free healthcare. And they have no money, and then they unnecessarily or very unreasonably try to fix the tariff. I think this is the whole issue which healthcare is struggling. And I think this is the time we address it. Otherwise, I think the healthcare go in the wrong way, and the entire population will be suffering.
No, thank you, Dr. Gyani. I think two things. Time is of essence. We must do it today because, we can't leave it for a later date because the whole viability of healthcare institutions. And secondly, what you said is that the cost of delivery in the public sector is very high. And, if that's taxpayer money, it's not free. Can we make better use of those resources? Mr. Venkateshwaran, I think one of the things you did mention, and I want to go, is obviously, very innovative how you managed to, accredit. But as we move our NABL standards over to more global benchmarks, what are the areas you think need to be addressed as we go ahead? Since, testing is in the limelight, and obviously we like to be the best in the world.
Yeah, NABL is already MRA signatory to APAC and ILAC. So mutual recognition arrangements are there in place, and NABL accreditation, if it is been obtained, that itself is having an international benchmark with respect to the standard what is being followed by the labs. Because this standard in which we are granting accreditation is ISO 15189 standard. The same standard is being followed throughout the world. And every country has got an accreditation body which operates based on ISO IEC 17011 standard, where NABL itself is complying to this standard. This is a general requirement for accreditation bodies which are granting accreditation to labs. Right. NABL is also granting accreditation to other labs also other than medical, like for testing laboratories, calibration laboratories. There also we follow a standard ISO IEC 17025 standard. So already these international standards are being followed by the particular labs which we are granting accreditation, and the equivalents among the countries are being established as NABL is a MRA to that. So from the year 2000 onwards, NABL is a signatory to the Asia Pacific Accreditation Corporation as well as to International Laboratory Accreditation Corporation. So these results are being exchangeable, and these are all being acceptable to more than 100 economies throughout the world.
No, I think that's very impressive, because I think that forms the bedrock as we go ahead. And obviously, if you have the best standards and then you perpetuate that throughout the country, it's going to have much more impact. I'll go back to you, Dr. Kocher. And one of the things we found during the pandemic was, uh, you know, both the caregiver, the doctor, the patient, everybody got impacted. So when the demand comes back, a lot of this demand will not be physical demand. Today as a physician, when I see a patient, I want to see him physically because I think I know his history. There's empathy in the interaction. And I feel that, it's a creative process of giving a final decision. But given that circumstances, you can't just do it anymore. So there's going to be a whole amount of demand which comes in, which is virtual. And a lot of the accreditation should be, if we're going to have a virtual consult, it's going to be different. So you need to see that accountability in a virtual consult, because the IRD has recently that it will be reimbursed. So if it is reimbursed, there should be no way the quality of that consult compared to a physical consult is compromised. So you were telling me that NABH has been on the forefront of putting this together. So it'll be good to understand that.
Rana, that's a very good observation which you made regarding the virtual or the teleconsultation. And this has been an opportunity actually which has purely arisen out of the madness which is all around us. Because the Board of Governor in supersession of the MCI gave us a gift of legalizing the teleconsult by a very robust document, which is the first time in the history of India, actually, they made legal. I mean, it is now legal to give you a prescription for a doctor to give out a prescription on a virtual platform. So this is a very good gift, but it also it is comprehensive, but it's a beginning, it's a baby step, but it has led to so many different questions about the legal indemnity, the consent, the empathy. I mean, we'll not go into the emotional quotient part at all, but there are so many other loose ends, the gray areas, and to fill that up, and in spirit of the Atma Nirbhar project, actually, on a steadfast way, NABH took it upon itself to initiate the digital health technology standards. And we have already initiated these standards. It's a very robust standard. The drafting committee has been very, very fortunate that way, that we have the nomination of all big and small stakeholders. We have nominees from Ministry of Health and Family Welfare, Bureau of Indian Standards, NITI, WHO, and CDAC, National Resource Center for Health, EHR. So practically it's a big team, and our only goal is to give a very cohesive, palatable document which will give clarity on all issues, not only telemedicine, but also issues of mHealth, also issues of interoperability, about the privacy scenario, the security of data, the who's the custodian of the data, how to keep that data which will be generated. So all these things, and the training is also a very crucial areas. So how to reach and take this further, actually, how to make the last people in the mile connect with that, actually, how to take it to tier 2, tier 3 cities. So digital health technology standards of NABH are going to be a very robust document. We have thought of a systems approach. We have thought of a graded system. I mean, it's not going to be very advanced, so that we don't want to confuse people. We are going in for a 3-tier model: the base level, the middle level, and the advanced level. Advanced level will also talk about, the medical value travel facilitators, actually. So what kind of information needs to cross borders? I mean, as of today, it's not legal to give a teleconsult across borders. But going forward, actually, there's so much opportunity. Like you said, if we are to reach, Dr. Chatterjee rightly pointed out about the role of technology. Arjun also pointed out about the role of technology. So if technology has to be incorporated, and please believe me, that's the only way out. If we are to reach the masses, we have to deploy and customize technology, and that technology needs to be guarded, actually guarded by so many parameters, not to make it obtrusive, but to make it people friendly also, but yet securing their rights and their privileges also. So this is what DHS standards of NABH claim to be and plan to be, and we hope to give it as early as 3 months. Already advanced levels of discussions are underway. Our technical committee, like I said, is very robust, and they're very hands-on people. And already Government of India has given so many wonderful guidelines in public domain. You know, the e-prescription, the e-Sanjeevani project of CDAC, the National Resource Center for EHR, CDAC version 2. I mean, these standards and guidelines are already in place, but they have to be taken to masses and taken to ready to be adapted by small to big hospitals. So this is like telemedicine, teleimaging, that's just one core component of all these things, besides the other consent, legal and other angles to it. So digital health technology standards is much to look forward to, and NABH is very proud that it's the first in the world. I mean, there's no other country in the world, and we have done our research, and we are in consultation with all thought leaders, you know, from NHS, from Australian digital health, and practically every stakeholder in the world is contributing, and we expect to have a very clear document in a simple English, which will be of much use going forward. So that's something to look forward to, and that's a big thing to happen to out of the pandemic, actually. A silver lining, you can say, as yet.
Yeah, I totally agree with you. And I think it's wonderful you're doing this, because I think in India, we are not, we won't follow traditionally any healthcare system. Because you have you have a geographical access to care, but 70% of our healthcare infrastructure is just in 20 cities, and not going to change very. Secondly, we spoke about the financial access, and like Dr. Gyani said, there are challenges on reimbursement. So I think the only way we can provide healthcare is going to be through technology, because we'll have to reach out through technology and do it differently. If we keep waiting for the traditional matrices of doctor per bed, nurse per bed, infrastructure, that's going to take a long time. So I think technology will help us actually take the winning leap to the next level.
Correct.
And Arjun, I'll ask you on the same thing, because labs were very different. Technology has changed them. And if you were to look at your lab in 2030, how do you envisage the lab services? What are things you'd be doing, but more importantly, what may be things you won't do because AI, data analytics would make them redundant? Arjun?
Sure. So that's a very relevant question. And when I picture myself in the lab, maybe 10 or 20 years from now, I see that technology will play a very critical role in not only adding value, but also helping us cater to higher volumes. So I'll give you an example. For example, the Apple Watch that everyone is wearing these days, it's come hugely in a way of wearables. So just a small story that an NBA player, a basketball player, was wearing his Apple Watch, and the watch actually detected a small arrhythmia. And later on, he was directed to go to the physician, who actually diagnosed him with hypertrophic cardiomyopathy. Then with that same diagnosis, the NBA player's family members were also checked with genetic testing, and even his family members tested for the same. So again, just by a simple wearable, that's a watch, we were actually able to add value and give a lot of medical advice and prolong the lives of these simple people. So definitely wearables is very near. It is going to add a lot to diagnostics also. Also, I was reading somewhere that 10 to 20 years down the line, there might not be a lab. It might be a lab inside a chip. So it will be constant monitoring of your body tests that you require. For example, glucose monitoring that we're already seeing with glucose monitors. So obviously for all of this, a lot of R&D is required, a lot of also inputs by artificial intelligence, not only to decrease the time of the expert doctor, but also to give you more accurate and precise information is the need of the hour. And apart from obviously providing quality and also training that has been emphasized, a lot of time also needs to go into research and development, because that's the way that we'll be able to move forward in this world, where we need to give the absolute best to all our patients.
No, thank you, Arjun. I think, and that's going to be very scalable, very replicable. And it's also because, accessibility to healthcare in India is always limited by affordability. So one, we can keep saying, but there is, like we said, quality comes at a cost. So can you really then make a paradigm shift and make it cheaper so it gets more accessible? Uh, Dr. Chatterjee, I'll go to you next. And one of the things we obviously say is that we detect disease very late. And, that's got its own implications because both morbidity and mortality are different. Also, as a country, if we go ahead, if we have late detection of disease, we just don't have resources, both the capital, the fiscal need, and the doctors to do it. So early detection will become important. And like Arjun said, in the preventive, the lab space, technology is transforming it. How do you see the preventive healthcare space being transformed by technology?
So, Dr. Mehta, rightly you mentioned, in fact, it's the bullseye when you say the point that how preventive health will help. And if we collectively look into the challenges which we spoke of on the healthcare infrastructure so far, from various angles, accessibility, reach, infrastructure, bed maintenance, cost per bed, costs per bed, transferable cost per bed, conversions, and at the same time, the level of training of the manpower, which is another critical factor. So, having said that, predictability of diseases is probably the only way by which we can prevent and overcome what we have today in the times to come. And preventive healthcare is the only mainstay which kind of can build up that structure of the predictability. And when we say predictability is not about a diagnosis, predictability is not about a cure, but predictability is about building up a person's lifestyle momentum. Dr. Dang also gave the reference of our Apple Watch, and we don't know today, but then we definitely know for us reason for sure that whatever Apple does, they do it for a purpose. And the Apple Health app is not on the phone just to measure the BMI indexes and the body health and weight and the number of steps and the calories burnt in a day. It has a reason for much more. So we have cues in front of us. We know what's going to happen in the times to come. And preventive healthcare talks about getting back into a person's life, building up the history from his family, from his past, putting it up, availability in front of him, mapping him day in, day out by his way, his lifestyles, his interactions. And then it will not change, I would say, overnight. The technology will not make something that, if we start implementing it today, it will change from the next week itself. Because the technology needs to be imbibed well with the human. So once these two come in contact together, and after they have coexisted in a way for roughly about a year's time, that's when that technology will start rewarding the reason for which it has been brought in. And preventive healthcare, once again, is largely about building up that platform wherein that coexistence can become much more meaningful. So we have been trying to modulate on various structures, both internally and with external stakeholders as well, of trying to walk them through, take them through, and making them understand how this technological interference will make them relevant. Two, while we speak of all of this, there's also another data point which is looking in front of us, and that is our country getting into a youth-dominated country in another about 6 to 7 years of time, which means for the next 120 to 130 years going forward, we are going to be called a youth-centric country. Now, the maturity, I would say, or the seriousness of health vis-a-vis somebody who is a 40, 45 plus, or somebody who is probably in the 2025s, are very two different yardsticks. Decision making, how to do, what to do, when to do, would be largely dependent upon a group of people who would be between 25 to 35. And how they handle things is much more important than how they resonate to things. And when we talk of resonation towards things, we have to make things which will be more applicable, likable, and approachable by them. And hence, once again, if you connect the dots, that's how your technology and the technology platforms, whether it be through apps, DIYs, POCT tests related to lifestyle development, making a health buddy, creating a health mentor. Today, we see an influx of mentors in the corporate world. We have young CEOs coming across at various levels. And then when they are stuck with the decision-making process, we have somebody else coming in who is a 65 plus to help him say that, yes, go on with your right and don't fail if you're wrong. So similarly, the health also will have their set of health mentors there built up in the point of time. So we will see a very different kind of a transition, and preventive health will, over the time, the way probably I see it and we see it here at Apollo, is going to become the mainstay for the livelihood for many, both in terms of employment and also for people who are taking the benefit out of it.
Exactly. I think it's not a choice. It's become an imperative for us as we go ahead. So thank you. Thank you for that enthralling discussion. I think, it was really amazing, and we could keep...
Quick points, just 2 quick points regarding the, I think, government's cognizance of the fact that wellness and preventive status is very important, because as part of the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, there's a provision for wellness also in a big way, about 150,000 centers, of which 12,500 are governed by Ayush Ministry, and NABH is again to partner with those, giving them a entry level Ayush certification. So I think this is a big number. And secondly, talking about Apple, I totally concur with what Dr. Arjun said and Dr. Chatterjee said, but there's a need for a red flag here also, because of the talking about the female Steve Jobs, the Elizabeth Holmes of Theranos, the bad blood. Yeah, the bad blood fame. I mean, so talking about point of control, those testing and all that. So I mean, so there, and that too will be governed, because the wearables and point of place testing and all those things, M-Health, will be again governed by NABH digital standards. So just quick submission.
No, I think that's important, and we'll put that. So just to end, I said, it's been an enthralling discussion. I think we've covered a lot of things which are relevant, and especially during this pandemic. I think the silver lining in the pandemic, helps us put the building blocks for a better healthcare future for all our citizens. I think Dr. Gyani started off and has said, healthcare has to be viable for the private sector. Otherwise, it's going to stymie the growth. And, we already have a supply side shortage. If the viability is impacted, this is going to have a double impact on us. Mr. Venkateshwaran, I think, very rightly spoke about the component that quality is very important, and especially on diagnostics. Since so much depends on a correct test, all the clinical decisions, and in the pandemic, the whole contagion could be different if you don't have that. And how do we really focus on that? Dr. Kochhar, I think one of the most important is, as we are moving away from traditional healthcare delivery to digital healthcare delivery, how India is in the forefront, and we are putting those standards before other countries. And that becomes very important as we have the technological access to health. And as Arjun said, technology is going to make it scalable, replicable, affordable. And the labs of the future would be very, very different, but they would be much more relevant than they're today. And finally, as Dr. Chatterjee said, preventive health is not something option, it's an imperative. If we don't look at preventive health, we don't have the resources, both financially and clinically, to be a healthy nation. And that can become one of the biggest roadblocks as we plan to take our GDP back, hopefully, to double digits. So I want to thank all my panelists, and I want to thank ET Health World for arranging this, and hope you have a wonderful day. Thank you.
Thanks for such fascinating back and forth. I'm glad that you're spending time with us and engaging in meaningful conversation. So do share your learning in the comment box and let us know about this platform, and I hope you are enjoying it and using it for fullest by networking and scaling up your reach. So do share your feedback about the session at the end, and you can also interact with us using the social media using our hashtag ETHealthIDS.